Okay, so another topic is diarrhea. Diarrhea is defined as increase in frequency and water content of stools. And there are two types of diarrhea. One is acute diarrhea and another is chronic persistent diarrhea. Acute diarrhea is defined as abrupt onset of three or more loose stools per day and lasts no longer than 14 days. That is acute diarrhea. While chronic persistent diarrhea is defined as episodes of stools that last more than 14 days. That is known as chronic persistent diarrhea. So acute diarrhea lasts only less than 14 days, while chronic diarrhea lasts more than 14 days. So this is difference between acute and chronic diarrhea. And now chronic versus persistent diarrhea. In chronic diarrhea, there is defined as the diarrhea that occurs longer than 14 days, while persistent diarrhea lasts longer than 14 days, which are caused by infections, while the etiology of chronic diarrhea is non-infectious. So chronic diarrhea occurs because of non-infectious causes, while persistent diarrhea occurs because of infectious causes. So chronic diarrhea, which occurs because of non-infectious causes, are because of lactose intolerance, celiac disease, protein energy malnutrition, cystic fibrosis, inflammatory bowel disease, immunodeficiency, or pancreatic deficiency. So these lactulose deficiency and celiac deficiency and protein energy malnutrition, cystic fibrosis can give rise to the non-infectious causes of chronic diarrhea, while infectious causes of persistent diarrhea occurs because of improperly treated acute episode of diarrhea like E. coli, Shigella, and Salmonella causes persistent diarrhea. Now the other types of diarrhea are osmotic diarrhea and secretory diarrhea. Osmotic diarrhea occurs because of when that stops when feeding or medication is discontinued. Osmotic gap is more than 50 and lactose intolerance is the cause of osmotic diarrhea, while secretory diarrhea is the diarrhea that persists even when the patient is fasted. Osmotic gap is less than 50, and the example of secretory diarrhea is cholera. So acute diarrhea occurs when diarrhea occurs or loose frequent stools occur less than 14 days. Diarrhea is one of the leading cause of the death like pneumonia and premature birth, and the causes of acute diarrhea are bacterial, viral, and parasitic causes. Bacterial causes are E. coli, Salmonella, Shigella, Campylobacter, and Clostridium difficile. Viral are rotavirus and enteric adenovirus. Rotavirus is most common cause of viral diarrhea. Parasitic are Gardnerella most commonly occurs in extraintestinal infections like urinary tract infection, pneumonia, hepatitis. Other causes are overfeeding, lack of breastfeeding, poisoning, and antibiotic therapy can give rise to the diarrhea. Investigations for diarrhea are CBC, serum electrolyte, detailed stool examination, stool culture, blood culture, X-ray, chest can be there. Complications will be dehydration, electrolyte, acid-base balance, bacteremia, sepsis, and death for the diarrhea. Management for diarrhea is uh, give plan A, plan B, and plan C. In these plans, different strategies are required. We will discuss. And in plan A, we have to give fluid food and follow up for the baby. And in some dehydration, what happens? We have to look at the condition of the baby. If baby is restless or irritable, his eyes are sunken, thirsty, and eager to drink, skin pitch goes back slowly, then plan B is start. And in plan C, we have to give baby uh, crystalloids, normal saline, and frequent sips of ORS. And we have to give baby. We have to look at the condition of baby will be lethargic, unconscious, very sunken eyes, skin pinch goes back very slowly, and drinks. And if baby is unable to drink, so plan C is recommended. Now in plan A, a mother should be evaluated for breastfeeding, ORS should be given, and fluid should be given to the baby. In plan B, zinc plus IV fluid and ORS sips with frequent breastfeeding should be given. And plain C is given when a baby has severe dehydration. And in plain C, we have to give IV and oral rehydrating substances, extra fluids, zinc, and continue breastfeeding. And excessive breastfeeding will be given in the plain C of the baby. If there is bacterial infection like Campylobacter jejuni, oral erythromycin along with rehydrating substances should be given. If it is Clostridium difficile, then vancomycin and IV metronidazole should be given. For Gardnerella, metronidazole should be given. For entomobacterial tuberculosis, same metronidazole is given as the drug of choice. So, in this way, we can manage the diarrhea of the baby and we can save the life of baby, because diarrhea can cause dehydration and dehydration may lead to some dreadful complications. In this way, we can treat the diarrhea. And another condition which occurs most frequently in children and neonates is measles. Now, measles is caused by RNA paramyxovirus. Incubation period is 8 to 12 days, and mode of transmission is through respiratory droplets. Measles is spread through nose, throat, mouth. From the infected person, virus is transmitted, and the clinical features of measles are prodromal features like cough, coryza, and conjunctivitis with coplic spots. These are grayish spots on buccal mucosa and manifest for 2 to 3 days. In measles itself, rash is characterized by cluster of lesions with white lesion on buccal mucosa opposite to first and second molar teeth. In this way, maculopapular rashes starts from the neck behind the ear, then spread downwards. Maculopapular rashes occurs in the baby of the measles, and complications are otitis media, bacterial pneumonia, encephalitis, subacute pain sclerosing encephalitis are the complications for the measles. And the management for the measles, we have to give supportive measurements like rehydration and antipyretics. For fever management, vitamin A is important, which should be given in order to prevent uh, corneal ulceration and corneal xerosis. Vaccine against measles should be administered at 6 to 9 months of the baby's age, and prophylaxis should be given. So in this way, we can manage the measles. And the another disease is varicella zoster virus or chickenpox and shingles. Varicella zoster virus causes chickenpox. It is DNA virus, and there are two diseases caused by varicella zoster virus: primary infection, which is known as chickenpox; reactivation infection like shingles or herpes zoster virus. Chickenpox is DNA virus. Incubation period 10 to 20 days. Occurs in children and occurs rash, which was mode of transmission are congenital, neonatal, acquired, and congenital transmission occurs during pregnancy of the mother, and neonatal occurs in neonatal period, and after acquired occurs because of respiratory droplets. Clinical features of the varicella zoster virus infection chickenpox are teardrop vesicles with dewdrop are rose petal spores with rash are centipetal, high grade fever, and complications will be bacterial super infections and pneumonia, encephalitis, Reye syndrome, hepatitis, infectious agents during pregnancy can causing teratogenic effect on the baby. Management of chickenpox should be given immunoglobulins should be given, and supportive management treat the second infection. Proper hydration, aspirin should be avoided, and calamine lotion should be given. And the another topic is neonatal seizures. Neonatal seizures are conditions in which seizures occur in first 28 days of life. These are called as neonatal seizures. So the etiology or the causes of neonatal seizures are most commonly hypoxic ischemic encephalopathy because of birth asphyxia or hypoxemia or decreased oxygen supply to the brain damage occurs and seizures develops. So birth asphyxia or hypoxic ischemic encephalopathy is most important cause. Another is birth asphyxia or developmental malformations in brain, intraventricular or intracerebral hemorrhage, maternal withdrawal of medications, transient metabolic disorders are the conditions like hypocalcemia can develop this condition, hypomagnesemia, hypoglycemia can give rise to seizures, infectious conditions can elicit the seizures like meningitis, septicemia, tetanus, neonatorium, intrauterine infection can give rise to neonatal seizures. So The other causes conditions are the metabolic errors can also give rise to seizures like phenylketonuria, maple syrup urine disease, and galactosemia can give rise to neonatal seizures. These are the etiological factors of neonatal seizures. So, what investigation will we perform in seizures? For seizures, we will perform EEG, electroencephalogram. CBC should be looked for electrolyte, and serum glucose, calcium, magnesium level should be looked. Urea, creatinine, and electrolyte should also be assessed. Blood culture for looking at any type of the sepsis, lumbar puncture for meningitis, metabolic profile for inborn metabolic errors of the newborn. So these investigations are mandatory for diagnosis of seizures. Management will be hypoglycemia management should be done because hypoglycemia can give rise to seizures. Hypocalcemia should also be managed. Give 10% dextrose water to manage hypoglycemia, and also calcium glucose. If not given 10% calcium gluconate, then maintain calcium IV line. A calcium IV should be given, and anticonvulsive therapy like phenobarbital and phenobarbital are also given. If diazepam, if seizures are not controlled with phenobarbital, then diazepam is given. In this way, we can manage the seizures of the baby or newborn. So in this way, we can save the life of a baby. And then the other condition which can occur in neonates is neonatal sepsis. It is bacterial infection. When bacterial toxins goes into the blood, then neonatal sepsis develop, and positive blood culture occurs in neonatal sepsis. It is divided into early onset and late onset sepsis. In early onset, infection occurs with causative organism of GB, Streptococcus, E. coli, and Listeria monocytogenes, while late onset sepsis is caused by GB, Streptococcus, Strep aureus, Pseudomonas, E. coli, Candida. So these are the late onset causes of sepsis. In early onset, presentation will be pneumonia less commonly as septicemia and meningitis occurs, and occurs most commonly in low birth weight babies. Early onset sepsis most commonly occurs in low birth weight babies because they have low weight and they are prone to develop multiple infections because of lack of immunity. Prolonged labor, rupture of membrane, foul smell liquor, multiple vaginal examinations, maternal fever, difficult prolonged labor, and aspiration of meconium can predispose to this condition. And the late onset sepsis occurs in low birth weight baby, lack of breastfeeding, poor cord care, superficial infection like umbilical cord infection, sepsis, and necrotizing enterocolitis, or disruption of the skin integrity by needle prick in IV fluid usage. So these can give rise to the late onset sepsis. Clinical feature of the sepsis will be baby will refuse to feed, baby will be lethargic and unresponsive, poor troy will be there, hypothermia, cold clammy skin will be there, breath problems, apnea will be there, full fontanelle will be there, diarrhea, vomiting, fast breath, chest retraction, grunting, seizures, and near neck retraction, bulging anterior fontanelle or full fontanelle occurs. Shock can be there, renal failure, and death, probably death of the baby can also develop in sepsis. So in this way, a baby of sepsis develop presents. Investigations for sepsis will be, we will perform CBC, blood culture, C-reactive protein, lumbar puncture, and neonates with organ-specific sign should also be managed by sepsis. Treatment of sepsis is, if we know that it is caused by most commonly bacteria and gram-positive bacteria, so antibiotics should be given. IV fluid, electrolyte balance, nutritional support, and maintenance of temperature is mandatory. Then specific management will be cefotaxime, ampicillin, and third generation uh, antibiotics should be given for management of the sepsis, ampicillin and cefotaxime. So in this way we can manage sepsis in the newborn. Then the other condition is torch infections. Torch infection is the uh, group of infections caused by toxoplasmosis. Other infections such as syphilis, hepatitis B, rubella virus, which causes German measles, cytomegalovirus, and herpes simplex virus. These collective viral infections is known as torch infections. So these infections can manifest during intrauterine life and can cause abortion, intrauterine growth retardation, intrauterine death, prematurity, deafness, chorioretinitis, microcephaly, mental retardation, anemia, thrombocytopenia, skeletal abnormalities, and many more diseases. So touch infections can develop like this. In this way, these conditions develop, and we can manage the patient accordingly. And shingles are herpes zoster. Shingles occurs when a person recovers from chickenpox. The virus remains in dorsal root ganglion of sensory nerves. Then varicella zoster virus, when reactivated later in life, causes shingles. And the clinical feature for shingles is very painful dermal distribution of the rash and fever. This is mnemonic, and that is PDF. And PDF, P stands for very painful condition, D for dermal distribution of rashes, F for fever occurs in shingles. So in this way this occurs. Rashes may last for 4 weeks with pain persistent for weeks or months with post-herpetic neuralgia in shingles. And rashes occurs with most common complications. Treatment for shingles will be acyclovir should be given in immunocompromised patient, and analgesics for pain control should be given. So here is the difference between measles and chickenpox. In measles, maculopapular rash develops, while in chickenpox, vesicular rash or dewdrop petal appearance rashes develop. In measles, RNA virus is causative agent, while in chickenpox, DNA virus is causative agent. And rashes start from face, neck, spread downward, and fades in same manner in measles, while in uh, chickenpox rashes are more on trunk or limb. In measles, non-itchy rashes are there with complicated spots, and prevention is measles, mumps, rubella vaccine. While in chickenpox, rashes are itchy and complicated spot does not found in chickenpox, and treatment is varicella vaccine. So this is difference between chickenpox and measles. Now these are rashes in measles, and these type of rashes are found. No, sorry, the different distribution is there. So the chickenpox rashes are like this: vesicular rashes filled with pus, and in measles these rashes, maculopapular rashes, are found like sandpaper. So this is possible distribution and the difference between chickenpox rashes and measles rashes. So in this way rashes occurs. Now the another complication or another disease occurs in children is mumps. Mumps is the infection which is characterized by RNA paramyxovirus. Incubation period is 14 to 24 days. Infectivity period is 1 day before or 3 days after swelling it appears. Mode of transmission is respiratory droplet and secretions. Through secretions, this disease can happen. Clinical features of the mumps is fever, headache, malaise, swollen salivary gland, especially parotid gland, unilateral or bilateral can be there. Complication of the mumps are meningoencephalitis, epididymoorchitis, pancreatitis, uveitis, myocarditis, arthritis. These are complications of mumps. Diagnosis for the mumps will be clinical, viral, serological diagnosis, and the management for disease will be supportive care, analgesic, bed rest, semi-solid fluid, and prevention will be measles, mumps, rubella vaccine. This vaccination can prevent the occurrence of mumps. Malaria is a parasitic infection which is caused by Plasmodium malariae, and there are 5 species of Plasmodium malariae. These species include Plasmodium vivax, Plasmodium ovale, Plasmodium falciparum, P. malariae, and P. knowlesii. This is new species of the Plasmodium, and the mode of transmission of Plasmodium is bite of female Anopheles mosquito, and malaria occurs. So the life cycle of the malaria is divided into two major phases. One is asexual phase and another is sexual phase. In asexual phase, which occurs and in exoerythrocytic phase and erythrocytic phase, and duration of this cycle is 48 hours in P. falciparum ovale and 5x, while 72 hours in P. malariae. So this is life cycle of malaria, which we have discussed in our previous videos. In this video, we will only look at the clinical features and treatment for malaria. So the clinical features of the malaria are a high-grade fever occurs with rigors and chills. So the possible important distribution between fever in malaria and fever in measles. The fever in fever in malaria and fever in typhoid. In malaria, fever is continuous in pattern, while in typhoid, fever is step-ladder pattern. Step-ladder pattern occurs. In malaria, fever occurs with a discontinuous phases, while in typhoid there is continuous high-grade fever remains, and that is step-ladder pattern of the fever. So this is distinguishing point and difference between the fever of malaria and fever of typhoid. And the malaria species are P. vivax and oval, ca- causes benign tertian fever on every third day with hypnozoites can cause relapse. With P. vivax is most common in Pakistan, and P. malariae causes quartan fever, while P. falciparum causes black water fever and cerebral malaria. So these are distribution and different causes of fever, different types of fever caused by malarial species. Diagnosis of the malaria will be based on JAMSA thickened thin smear and ICT immunochromatographic test is diagnostic test for malaria, and the management will be supportive care, hydration, antipyretics, blood transfusion if necessary. Specific care for each species of the malaria should be the drug of choice for malaria is chloroquine, while for falciparum is quinine plus pyrimethamine with sulfadoxine, and mefloquine is the drug of choice for falciparum. But the prevention of malaria is environmental protection, wearing long clothes, and mosquito repellent should be applied on the body. Chemoprophylaxis drug should be given once weekly every week and starts in 1 to 2 weeks before going to endemic area, and in this way we can manage malaria. Typhoid and paratyphoid fever are also known as enteric fever. These are types of fever which are caused by Salmonella typhi and paratyphoid Salmonella paratyphi A, B, C serotype. Incubation period of this fever is 7 to 14 days, and mode of transmission is fecal-oral. Outbreak of disease may occur by contaminated water or ingestion or eating raw egg. So the clinical features for this fever are high-grade fever, which will be continuous in nature, and step-ladder pattern occurs in this fever. So step-ladder pattern is a high yield point, and it is differentiating point between malaria fever and typhoid fever. In malaria fever, there is irregular type of fever occurs, while in typhoid there is continuous fever, which is known as step-ladder fever. And in typhoid fever, headache occurs, anorexia with abdominal pain along with constipation because of Peyer's patches narrowing lumen. Constipation occurs and relative bradycardia occurs in first week. In second week, rose spot develops, splenomegaly, distension of abdomen, and diarrhea occurs. In third week, there is delirium, life-threatening complication like GI bleeding and perforation can occur, and myocarditis, pneumonitis, and pancreatitis. Pancreatitis can develop, while in fourth week, recovery period begins if patient survives. Then, in this way, these different clinical features are seen in typhoid. So, the diagnosis for typhoid fever are BASU, BASU, VASU. B for first of all, blood culture is preferable for typhoid, then agglutination test, Vidal test, and typhoid test. Vidal test with typhoid test is the important, and then C stool culture should be performed with urine culture. These are diagnostic criteria for typhoid fever. And then finally management is performed. For management, supportive, specific, and preventive management should be performed. Supportive management will be proper hydration, nutrition, blood transfusion, and surgery if intestine is perforated. For specific management, ceftriaxone, cefiximine, and fluoroquinolones should be given. And for prevention, hand washing, improper hygiene, improve hygiene and clean water should be given. Raw egg should be avoided with passive immunization of vaccine should be given in typhoid fever. So in this way, typhoid fever can be cured. Tuberculosis is very dangerous disease, occurs in children most commonly. Tuberculosis is an infectious disease caused by Mycobacterium tuberculosis, and tuberculosis generally affects lungs, but it can also affect other parts of body like meninges and bone, spine, lungs, spine, lungs, and pericardium, tuberculosis of the pericardium. So in this way, it affects multiple organs. Etiology of tuberculosis is Mycobacterium tuberculosis are acid-fast bacilli. Mode of transmission is respiratory droplet. So this is for pulmonary tuberculosis. Pathogenesis is bacilli are inhaled and lodged into alveoli. Then bacilli initiate recruitment of macrophage and lymphocyte, and then surviving organism multiply by disseminated via lymph nodes and blood stream, and then macrophages are transformed into epithelioid Langerhans cells, which causing caseating granulomas and Gun's focus. Gun focus is primarily lesion characterized by aggregation of numerous granuloma, and Gun complex is combination of calcified primary lesions, and Renki complex are formed when Gun complex undergoes fibrosis and calcification. In this way, Gun's focus, Gun's complex, and Renki complex develop in tuberculosis. Then the latent phase or latent period of the tuberculosis comes when patient is infected with the Mycobacterium tuberculosis, and patient does not have active tuberculosis. Epidemiology is recent immigration in adults and children, especially in girls who are prone to develop active tuberculosis. And the clinical feature for tuberculosis, first of all, constitutional symptoms occur like fatigue, anorexia, night sweats with weight loss occurs, and then the pulmonary TB develops with chronic productive cough, hemoptysis, consolidation, lymphadenopathy, non-resolving pneumonia. With miliary TB, there is wide dissemination of infection in lung, abdominal organ, and marrow, with CNS occurs. Chest X-ray shows multiple small millet seed appearance in miliary TB, and this is high yield point. And extrapulmonary TB occurs in lymph node, in gastrointestinal tract, in pericardium, in CNS like meningitis and tuberculoma, and in bone and joints occurs like port disease or source abscess, and common in the spine of the lower thorax and lumbar region. So in this way, pulmonary TB disseminates to the other organ. So the investigation for TB will be screening for latent phase, Montauk's test, tuberculin test should be performed, and in induration phase, patient should be given routine X-rays, and in this way tuberculin test is performed, and TB is diagnosed. So the diagnostic test will be chest X-ray will show consolidation with hilar lymphadenopathy, biliary hilar lymphadenopathy. In miliary TB, there's millet seed-like appearance in the lung will be there. Then sputum staining and culture is performed for looking at which type of looking confirmation for acid-fast bacilli, and then sputum gene X-ray are nucleic acid amplification should be performed. In this way, we can diagnose the TB, and then treatment starts with isoniazid for 9 months. And if active TB infection is there, then isoniazid, rifampicin, and paracetamide should be given. And if TB meningitis is there, then corticosteroids should be given for uh, relieving inflammation of the meninges. Then extended treatment if there is HIV positive, then the management will be in different contexts, and tuberculous osteomyelitis should be treated differently with miliary TB and meningitis with different ways of the treatment. But these five important drugs like isoniazid, rifampicin, ethambutol, and paracetamide with streptomycin are the mandatory for TB treatment. So as you can see, these are the X-ray showing lymphadenopathy of the patient with primary TB, and chest radiograph shows bulky left hilar, right paratracheal masses with typically lymphadenopathy showing in the patients. So in this way, TB X-ray are present in the patients.